Honest, open communication between patient and doctor about the person's preferences for care at the end of life helps to ensure the best possible quality of life during a fatal illness. The doctor provides a candid assessment of the likelihood of recovery and disability during and after various treatment options, and the person tells the doctor and his family what he wants and he does not want to experience. The person's health care decisions may include choosing a doctor and a system of care, stating his preferences for treatment and the limits he wants placed on that treatment, expressing wishes concerning where he wants to die and what he wants done when death is expected, and stating whether he wants to donate his organs after death. When choosing a doctor, a person should ask about care at the end of life. Does the doctor have substantial experience caring for dying people? Does the doctor care for the person until death in all settings, hospital, nursing home, or home? Does the doctor treat symptoms, fully palliative care at the end of life? Is the decent doctor familiar with the home health, physical therapy, and occupational therapy services in the community? Who qualifies for them, how they are paid for, and how to help people and families get more intensive services when needed in some cases when a doctor may lack an experience in offsetting by a trusting, long-standing relationship that exists between the doctor and a patient and family, and by the doctor's willingness to consult with other experts. A system of care includes a financing system, such as the insurance policies and managed care, and a care delivery system, such as doctors, a hospital, a nursing home, and home health care agencies. Asking questions of doctors, nurses, other patients, and families, social workers, and case managers can help a person find a good system of care. What treatments are available in the system? What information is available about the merits of possible treatments? How can a person talk to other patients and families who have been treated there? What experimental treatments are available? How have other patients done with these treatments? How are these treatments paid for? Often the available choices are between dying sooner but remaining comfortable and attempting to live slightly longer by receiving aggressive therapy, which may increase discomfort and dependence. Nevertheless, dying people and their families may feel that they must try such therapies if any chance of prolonged survival exists, even when hope for a cure is unrealistic. Opportunities of philosophy, values, and religious beliefs come into play when such decisions are made by and for a dying person. People should discuss their wishes for end-of-life care well in advance of a crisis that makes such information critical. A person nearing death is sometimes persuaded to try one last treatment, which often sacrifices the person's last few days to side effects without gaining quality time. The person and family should be skeptical of such treatments. In many cases, as a person nears death, the focus of care should shift entirely to providing comfort measures that the dying person does not suffer. Some decisions, such as whether to allow resuscitation, the only treatment provided automatically in the hospital unless specifically pre-decided otherwise, are less significant than they seem. An order against attempting resuscitation makes sense for most people expected to die, and such a decision need not weigh heavily on the family. The person who is near death before the moment when the heart stops beating and breathing ceases cardiopulmonary arrest is not likely to benefit from a resuscitation attempt. Resuscitation efforts can be prohibited in advance by directives or through discussion between a patient and doctor, with the doctor writing the needed order. Food and water given through tubes, artificial nutrition, and hydration are not often useful to a dying person and can also be prohibited in advance. Other decisions may include setting in which the dying person will spend his final days. For instance, the family may want to have the person at home, a familiar supportive setting, and not in a hospital. Family members should insist that doctors and other preferences and honor them. In some cases, hospitalization may be explicitly declined. The dying person may wish to donate his organs after death. This decision is best made with the family in accord if possible. In general, people dying of a chronic illness can donate only corneas, skin, and bone. People who die more suddenly can donate more organs, such as kidneys, liver, heart, and lungs. To become an organ donor, the person usually needs only to sign a standard organ donor card to let the doctor know of his wishes.
So. Shall I read?